Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota. Today we're continuing our Anesthesiology 101 lectures. We're discussing inhaled anesthetics. We're going to discuss a couple different concepts, the first being mean alveolar concentration, and then how inhaled anesthetics affect the cardiac system, the respiratory system, and the neuromuscular system. And then we'll finish up discussing two changes or things that you can do to improve your ventilation of a hypoxic patient, and two things you can do to improve your ventilation of a hypercarbic patient. So the mean alveolar concentration, otherwise known as MAC, is the concentration of an anesthetic that prevents movement in response to painful surgical stimuli in 50% of patients. So the reason this is useful is it kind of standardizes the effect that you're going to get using different volatile anesthetics. So there's some common MAC values. So I think explaining these might help depict the concept of MAC. So for isoflurane, 1 MAC equals 1.15% of this gas. For sevoflurane, 1 MAC equals 2.1% of the gas. Desflurane 1 MAC equals 7.25%. And then for nitrous, 1 MAC equals 104%. So, like how MAC is useful then is each of these gases, isoflurane, sevoflurane, desflurane, nitrous, to get 1 MAC, you have different concentrations of the gas that's being used. So if you were using two gases, maybe you were using nitrous and sevoflurane, it could be really confusing how much gas you should have on if you were going by the absolute percentage values. If you're using these two gases and you're trying to put someone to sleep, should you use 50% nitrous and then like 0.75% isoflurane, or how should you combine those two? Really confusing if you're looking at the absolute values. However, MAC values are additive, so you could, if you were trying to combine two gases, you could use a half a MAC of isoflurane and a half a MAC of nitrous, and then add those together to get the equivalent of 1 MAC. And that's like 1 MAC is a standard effect on the patient that you can kind of anticipate in understanding how deep into anesthesia they will be. And that's a lot easier to understand if you're using a MAC value, a consistent value, something that corresponds across different volatile anesthetics, than if you're trying to remember these specific concentrations. Another thing, just to clarify, so it might seem that MAC isn't super useful because it's preventing movement in 50% of patients. The reason that they chose this is ideally, you could have some standardized value that would guarantee no movement in 100% of patients. But statistically, that would be impossible. There's always going to be some patients who are resistant to the volatile anesthetic or moving for some reason. So you can't define a value that prevents movement in 100% of patients. So that's why they chose 50% of patients. And then if you are at 1 MAC value and that prevents movement in 50% of patients, and then you also have fentanyl that's being used, or propofol or some other agents, then around that 1 MAC value, you can anticipate that the patient would be deep enough in anesthesia to have no recall and maybe to have limited movement enough to perform the surgical procedure. So the massive benefit of MAC is you're defining kind of a universal concentration of 1 MAC or, more or less depending on what your goal for the anesthesia procedure is, but you're defining a universal standardized concentration that can be used across different volatile anesthetics. And then you can anticipate the same anesthetic effect no matter which of the gases you're using. So, the last topic about mean alveolar concentration that I'd like to discuss are some different variables that can affect your MAC value. So, generally in the OR, at least in Rapid City and Sioux Falls that I've seen, you'll enter a patient's age, and then the anesthesia machine will calculate what the MAC value for that patient's age is. So that's another way that you're even further standardizing the effect that you'll receive from the concentration of a gas that you're delivering to the patient. But that would be one of the factors that would influence your MAC. So uh, we'll say things that can increase your MAC, and then there's factors that can decrease MAC. So, like we're talking about here with age, MAC is greatest, or a patient's requirement for volatile anesthetics to put them asleep to induce anesthesia is going to be greatest at 6 months of age. And then as you get older, we'll say like elderly patients, that's going to decrease your MAC value because they will go to sleep or receive anesthesia. They'll be like more sensitive to the volatile anesthetic. Chronic alcohol use can increase your MAC requirement. So if they chronically are on depressant medication, then it makes sense that they might have a tolerance to that. And then they might also have a tolerance to a volatile anesthetic that functions on a superficial level, kind of similarly to a depressant. And then the opposite of that would be if they were acutely on like a stimulant medication, so like amphetamines. And if they were high on like methamphetamine and had tons of energy and were super alert, that would also increase your MAC value because you would need to use more of an anesthetic to provide anesthesia. And then physiologically, two things that I'll touch on. So hypernatremia and hyperthermia are both going to increase your MAC value. Kind of an interesting one. I've heard it debated between anesthesiologists, but the Baby Miller textbook reports that patients with red hair can tend to have higher MAC requirements, so they're less sensitive to volatile anesthetics. I think that currently in the literature that's a little bit in question, but historically that's been a variable that you would take into account. So we already said that elderly patients can have decreased MAC requirements. Kind of thinking in the opposite of what increases MAC requirements, but if someone chronically is on stimulant use, so then their baseline would be like a more depressed state, then they would have decreased MAC requirements. Or if they acutely had like alcohol on board, then in that moment they would be in a more depressed state, so they would have decreased MAC requirements, as opposed to hypernatremia, hyponatremia, is going to decrease your MAC requirements. Um, Hypercarbia and hypoxia will both decrease your MAC requirements. Hypothermia as opposed to hyperthermia would decrease your MAC requirements. Pregnancy, and then anemia. If someone's anemic below a hemoglobin of 5, can also decrease your MAC requirements. So inhaled anesthetics have a common effect on the cardiac system. The largest overall effect that you'll see from inhaled anesthetics are going to be a decrease in blood pressure. Blood pressure is composed of cardiac output times systemic vascular resistance. So inhaled anesthetics are going to affect both of these components. They're going to decrease your systemic vascular resistance, which is going to decrease your blood pressure. And the other large effect is going to be a decrease in cardiac output via a decrease in cardiac contractility. And then both of these combine to decrease your blood pressure. The other effect that you can see from inhaled anesthetics is going to be, so we'll call this the first effect, and then the other one is going to be an increase or prolongation in your QT interval. Now, I haven't seen this ever be a concern, like clinically in practice. I don't know if this is something that anesthesiologists have to be aware of. However, according to the Baby Miller textbook, this is something, an effect that you can see from inhaled anesthetics. So similar to the cardiac system, inhaled anesthetics have a common effect on the respiratory system. Probably the most well documented or described effect is going to be increase in respiratory rate, a more significant decrease in tidal volume, and then respiratory rate times tidal volume equals minute ventilation. Overall, the decrease in tidal volume predominates, so you're going to have a decrease in minute ventilation. The second large effect that you'll see from inhaled anesthetics on the respiratory system is going to be affecting respiratory drive. So inhaled anesthetics are going to nearly completely abolish the hypoxic ventilatory response. So your drive to breathe based on low oxygen, that's going to be like almost completely gone at surgical levels of inhaled anesthetics. They're going to, again, almost completely abolish your peripheral hypercarbic response. So your peripheral chemoreceptors that cause you to breathe based on increased carbon dioxide, that's going to be almost completely gone at surgical levels of volatile anesthetics. And then they're going to decrease your central hypercarbic response. So of these three drivers of respiration or ventilation, the one that's left most intact is your central hypercarbic response, and that's going to be what causes patients to be able to breathe on their own, is the accumulation of carbon dioxide detected centrally. And then finally, the third effect that inhaled anesthetics have on the respiratory system, I consider this kind of a miscellaneous category, but one of these is going to be bronchodilation. Sevoflurane is the best at bronchodilating. This is useful in a patient who is having an acute asthma exacerbation. The next is decreasing mucociliary clearance, and then also decreasing surfactant production. These two effects are hypothesized to leading to like an increased risk of pneumonia or atelectasis in the postoperative period. So inhaled anesthetics have a common effect on the neuromuscular system as well. They potentiate, so improve or strengthen the effects of non-depolarizing neuromuscular blockade agents. So that would be like improving the effects of rocuronium or becuronium. The idea of how this is accomplished appears to result from direct, non-competitive antagonism of the nicotinic acetylcholine receptors. So the volatile anesthetics seem that they can also antagonize the neuromuscular junctions, just like rocuronium or becuronium can. Um, there's some evidence that shows that inhaled anesthetics can also decrease acetylcholine release from the presynaptic nerve terminals as well. It's not super clear, but this effect of increasing the effect of the paralytics is well established. So I'm going to list 2 ways that you can improve oxygenation of a hypoxic patient. I'm sure that there's plenty of other ways to do this, and it gets a lot more complex than this, but these would be 2 of the most foundational or basic ways to improve oxygenation. So the first is very intuitive, so increase your fraction of inspired oxygen. Makes sense that if you increase the amount of oxygen that's being delivered to the patient's lungs, that can improve the uptake of oxygen and increase oxygenation. And the second is a little less intuitive, but increasing your peak and expiratory pressures, or PEEP. The idea of increasing your PEEP is if you increase PEEP, then you can improve your alveolar recruitment, and that like increases the surface area where gas exchange can occur. And then if you do that, that can improve your gas exchange and increase your oxygenation. So I'll list 2 or 3 ways to improve um, carbon dioxide elimination in a hypercarbic patient. So the first, this is probably the most common way. It's at least I've heard of this the most when being taught, is to increase your minute ventilation. Minute ventilation is composed of tidal volume times respiratory rate. So increasing either your tidal volume or your respiratory rate um, can assist in the elimination of carbon dioxide. The second is by placing the patient in a prone position. This allows for more even distribution of blood flow throughout the lungs to increase the like drop off of carbon dioxide and exchange of it into the lungs. And then the third is increasing your end inspiratory. So end inspiratory pause. It's titled very intuitively. So if you take a breath in and then hold that breath, essentially a breath hold, that would be the time that you have for inspiratory pause. So increasing the time you're holding your breath. The idea of doing that is when you hold that breath in there, that allows for more gas exchange to occur because there's more time where all of your alveoli are expanded and that you have gas within your lungs so that the carbon dioxide can exchange and then be blown out when you exhale. I hope this lecture helps you guys. Let me know if you guys have any questions.